Hello students, this is the lecture on somatic symptom related disorders. I am starting with this section and I'll move to dissociative disorders later because I think it ties better to the PTSD lecture that was the most recent one that we covered. Okay, so there are a couple of disorders in this category. We're going to start with somatic symptom disorder, then we'll talk about conversion disorder, and then finally we're going to talk a little about typical disorders that we might struggle to differentially diagnose between these two, which is malingering and factitious disorder. So I'll save those for a little later. Okay, so somatic symptom disorder, as I mentioned in the PTSD lecture, may be the flip side of the coin of PTSD. So when people go through trauma, if they experience the fight or flight response, then there's evidence to suggest that they may develop somatic symptom disorder because their body, in a sense, is remembering the trauma and being triggered by cues in the environment about the trauma and reacting to that, even though their conscious memory or their autobiographical memory, we might say the explicit memory system, was blocked by cortisol. Their cortisol levels shot so high in their fight or flight response that they were not able to encode memory for the actual event. Now, but we know that memory systems in the brain are dissociated, as in they are separate. They work sometimes in concert together, but we've found with various drug studies, as well as even looking at trauma survivors, that one memory system can be affected while another memory system is not. And so this seems to be the case with cortisol reaction in response to trauma. So people with this disorder may or may not, it's not every case that we can't know for sure, but we think that one of the reasons the prevalence is somewhat high in this disorder, that 5 to 7% of the population may experience this at some time in their life, is because it may be a response to trauma. And people are exposed to trauma at probably a surprisingly and unfortunately high level. But not everyone, of course, develops a disorder based on experiencing the trauma. But if they do have that fight or flight response, then it is quite possible that the high levels of cortisol would effectively block the autobiographical memory for the trauma, create traumatic amnesia, however, leave the other memory systems in the brain intact because cortisol doesn't appear to affect receptors in the amygdala or in the sensory motor cortex or in the cerebellum, where other types of memories are stored, like body memories we might describe in lay terms, and emotional memories like in the amygdala. So it is possible that the symptoms that people experience, these physical symptoms that are unexplained by a doctor, so if I get back up to the key features area, the main way that we diagnose this disorder is that someone is experiencing repetitive, painful, or uncomfortable, non-functional kinds of physical symptoms in some part of their body for at least a 6-month period of time that is unexplained by a medical doctor. So they've probably sought out consultation with an MD to try to figure out what's wrong with them, what's going on. They probably originally believed that this is some kind of a disease process happening. And if that's determined not to be the case, then they might be referred to a psychologist or a psychiatrist who could look at whether these symptoms have a psychological origin rather than a physical or a body origin. That's not to say that the symptoms are not real. They are, but their origin seems to be different. So the pain that people feel, which pain is generally the most common symptom in this somatic symptom disorder, in a particular anatomical site, they're experiencing repeated pain. Sometimes it's whole body, but often it's in a particular area of the body. And people that suffer from this usually have experienced pretty severe pain for long periods of time in more than one anatomical site before the age of 30. So, unusual for people in that age range to be experiencing a lot of pain when there's not a known medical condition going on. Okay, so yes, why might they be doing this? Well, like we said, the way that cortisol may affect the brain when it shoots as high as it does in people with that fight or flight response, it seems to have later in the cascade an effect on the sympathetic and the parasympathetic nervous system. And so the sympathetic nervous system being the one kind of moving through your spinal cord and out into your nerves, that gets everything sort of lit up and on fire and reactive, and the parasympathetic nervous system being triggered to kind of calm that back down into kind of a state of homeostasis. Well, we think, or at least some of the research that I've worked on, because this is an area of research that I've personally worked quite a bit in, that it's the process of calming the parasympathetic nervous system kicking in and calming the sympathetic nervous system that is interrupted or is prevented from happening. And so when I mentioned before, talking about PTSD, that people who then develop amnesia, however, the downside of that is that they may experience more pain. They don't get that analgesic effect that people with PTSD do in the first few days after the trauma. And afterward, it's possible that that system is then more reactive, that if any cue comes along of the trauma, that say for someone with PTSD, that cue will make them flood with memories of the trauma, maybe nightmares and flashbacks and all of that. In this case, it may make this person's body and the emotional systems flood kind of with body and emotional memories of the trauma. But of course, to them, it will seem to come out of nowhere. They won't recognize the cue that might have triggered that. So this can be very difficult to treat. And people can kind of think they're crazy. And sometimes we find that family and friends don't understand, or that even people in the medical community kind of want to blame the person or say that they're malingering, that these symptoms are made up or that they're making too big of a deal of it and that it's not a real disorder. But it wouldn't be in the DSM if we didn't have some pretty solid evidence that it is a psychological disorder that is very distressing to people. Okay, so it has some comorbidities with panic disorder and other like mood or like depressive disorders or anxiety disorders, possibly because there's that connection to trauma. Again, not in every case. People may be more prone to developing somatic symptom disorder, and we're not completely sure why, but there's a genetic component there. And if they're more prone to anxiety disorders, which we know is partially genetic, that may be part of the reason. They also, if they appraise trauma, as we said, in that fight or flight kind of mode, then that may make them more prone to develop this disorder. Okay, so what are some treatments? Like PTSD, probably the best type of treatment is exposure therapy, but it's hard to do exposure therapy when we don't exactly know what the trauma was. So sometimes therapists, body-centered therapists can do a pretty good job because, again, a lot of the symptoms are happening in the body anyway, and it may help the individual start to identify what triggers and cues are. They may not understand why something is a particular trigger for their symptoms, but in some ways, it doesn't matter if they understand why. The point is that they have to learn to adapt then, either start avoiding those triggers more or having techniques that they can kind of calm and reassure the body, try to bring it back into a level of homeostasis if they do get triggered. Sometimes this is just very difficult, painstaking work and isn't very effective. And so medication can sometimes help. Newer research and part of the project I'm working on is trying to look at targeted medications that maybe particularly affect the receptors in the PNS, so that people aren't just, say, on pain meds or that kind of thing, because if it's psychological in origin, pain meds aren't always that effective. And so if we can prevent the trigger from happening at the brain level before it gets down into the brainstem and the nervous system where the symptoms are occurring, that's what we'd like to see happen. So we need a lot more research in this area, but it is interesting disorder that is probably related to trauma. So I wanted to spend some time on that. Okay, so we're going to now talk a little about conversion disorder. Let me move to that slide. This is similar in some ways to somatic symptom because it tends to be somatic, but it's very neurological, the types of symptoms that occur. So really typical ones are blindness, if you can imagine, paralysis, numbness, stinging, and burning, because these are things that are typical of nerves and the way, kind of, if you think of your nerve being afraid, that's kind of what would happen. Now, what's amazing, I mean, is people that have conversion disorder, and this name conversion disorder is kind of the old term from psychoanalysis days, something basically Freudian, that he would argue, and he might not have been totally wrong about this, given what we know more about this idea of traumatic amnesia, but that people had kind of an unconscious need to cover up information in their psyche And so their body would sort of convert that information into a physical symptom. Does that kind of make sense? So it's sort of what I was describing before, but that idea that perhaps the body is reacting to something that the mind kind of can't handle or had to block or just simply couldn't encode. And that's why these symptoms might be occurring. We have a long way to go to really explaining this, but we do know that conversion disorder is made worse by stress, and it can come in and out, which also lends some credence to the idea that cues in the environment might be triggering it to come on, but people don't really know why. So something can happen like a person is driving a car and they can suddenly go blind. Their eyes stop working, their occipital lobe stops processing visual information. And of course, you might imagine this is terrifying, and people will, immediately want to go to the ER. The blindness can last for 30 minutes, up to a few hours, maybe even a few days. That's more rare. It usually is fairly temporary. And then their sight can return. And as you might imagine, it's baffling. And so, all kinds of tests will be run to try to figure out, if there's really something going on with the eyes or not. And in fact, it can be determined, if it is determined, that there seems to be no medical reason for this blindness. And if they have another episode of it where it's coming in and out, then, optometrists and people who study eyes knows that that's not normal. That does not happen. When there's damage to the retina or damage to the optic nerve or the occipital lobe, then you have a permanent condition, or it's a steadily decreasingly poorer prognosis as time goes on. And in this case, with conversion disorder, it comes in and out, and then their vision is completely fine in between. So that's an example, but it could happen with paralysis. People can't move, or a whole side of their body stops functioning, and their nerves truly are not able to function for that period of time, and then it can come back. Obviously, we have to kind of be careful that this isn't MS or some other condition where that type of thing can happen. Okay, so that's just a little bit I wanted you to know what conversion disorder was. Now, what about factitious disorder and malingering? And why are these easily confused with somatic symptom disorders? Well, factitious disorder is a rather horrifying condition. You might have heard of this. There have been some movies that have had little snippets of what this is. Munchausen syndrome is also another name for factitious disorder. And it's someone who is seeking care. Could be psychiatric care. It can be, more often it's the care of doctors, hospitals, nurses, that kind of thing, to be admitted and taken care of in a hospital setting, simply to get the care. And so they will falsify symptoms. They will actually make themselves sick so that they appear to have some kind of unexplainable or possibly explainable disease, and therefore will need medical treatment. And Munchausen syndrome by proxy, or factitious disorder by proxy, is when the person is making their own child or a loved one, an elderly person they're in care of, sick to get them more care. So it's very rare, but it's a terrible, terrible condition where someone has such a need to get some caretaking in their life that they're willing to poison themselves, cut themselves, poison someone they love, do things like that to be needed, to feel like they matter, or we don't totally know exactly why they do it, but this is different from somatic symptom disorder. So I hope that you can see that difference. That could be a little hard to determine depending on where you've been working with an individual with these kinds of symptoms. Malingering is also a falsification of symptoms, but it's a little bit different in that factitious disorder, usually, the person really does create illness in their body. They actually harm themselves in some way to try to get help, from the medical community. Malingering, they might do that, but often they're just faking symptoms in a pretty realistic way. They don't really want to be harming themselves in order to get out of some kind of consequence, like a legal consequence, even faking that they were really hurt in a car accident so that they can get a payment or something like that. And so that's a different situation. But I wanted to point all these out to you because you'd have to think about those things when you're diagnosing a client. Make sure you've got the right diagnosis pinned down. So I think that's enough about that, and I will talk to you guys later.